This is the,
The pulmonic one.
well, that's a pulmonic valve, this artery.
Oh, pulmonary artery.
Pulmonary artery is connected to the,
Right ventricle.
yeah. What kind of blood is here?
Deoxygenated.
And it's going to the lungs to get
Oxygenated.
Yeah. What is this structure called?
Ascending aorta.
The ascending aorta, okay?
Oh.
The aorta is connected to the,
Left ventricle.
Left ventricle.
what kind of blood is this?
Oxygenated.
And it's taking oxygenated blood out to the baby's body, correct?
Yes.
This is a normal heart. Yeah. Transposition of the great vessels means that this pulmonary artery is connected to the left ventricle. And the aorta is connected
To the right ventricle.
So the oxygenated blood is gonna go into
Exactly. So what's happening now is deoxygenated blood is going into the aorta and going out to the body. Very blue cyanotic baby. Okay? Yeah. So, the only chance that this baby has to survive is PDA.
Professor, but is it mixed blood or just the deoxygenated blood?
Which,
When that's happening?
no, it's deoxygenated. Let me show you how the PDA staying open helps. This is the PDA. You can't see it on this slide because this is a normal heart. Okay? But this is the PDA. The PDA connects the pulmonary artery with the aorta. Remember? So right here is the PDA. Okay? Okay. Now, the pulmonary artery is connected left ventricle. Correct? Okay. When the left ventricle pumps oxygenated blood into here,
go to the lungs.
the blood goes to the lungs. Watch me, watch me, watch me, watch me. The blood goes to the lungs, and if this is open, it also goes to the, that's
To
how
the
you
body.
get, that's how you get oxygenated blood out to that baby's body. So if the baby's born with transposition of the great vessels, you don't wanna close this. If you close this, now you can shut off any possibility to get oxygen in here.
So how do you control that with the lowering the FiO2?
I love it. Two ways, medication and lower the FiO2s. The FiO2s must be lower, so if you go into the NICU and you see a baby setting 75 and the nurses are chit-chatting, they're okay. No problem. That's where that saturation should be. What's wrong with you guys? 75 help this baby. They did help him. Okay? They did help him by leaving him 75. By leaving him 75, you decrease the chances of the PDA closing. Okay?
How long does that last for?
Yeah, 1 second.
How long does that usually last for?
Surgery.
Until surgery?
Yeah. He's gonna die if he doesn't get surgery. I'm gonna get your question in a second. You guys, 1 second. I won't lose my thought here. I just lost my thought. Go ahead. Sorry.
Does the CO2 plays a role in that?
Sorry?
Does the CO2 plays a role? Because that baby's gonna have a high CO2.
Absolutely.
So does the CO2 plays a role like keeping the PDA open?
No. No. What happens with a CO2 is you're gonna have what's called a CO2 narcosis if you decrease your ventilation. So what you want is to improve and increase your ventilation, but keep your FiO2 down. Allow your baby to desaturate, okay, on purpose. He's a little blue, okay. But he's getting some oxygen into his aorta, which is gonna go all over his body, okay? You close this, when he gets all over his body, is deoxygenated blood, he's gonna die, okay? That's what transposition of the great vessels. That's why this class is vitally important to understand the pros and cons of using oxygen. We always think oxygen is our friend. It is, but we have to know how to use it. It's a medical gas, okay? We have to know how to use it. So yes, continue your ventilation, regulate your CO2s, but keep your oxygenations down, okay? Now, I was still trying to get out of my thought.
Professor, so that baby's gonna be on a mechanical ventilator? You don't
Yes.
intubate it?
Correct, correct. How do you identify, how do you identify a baby that has cardiac anomaly? if a baby's born, you're at a delivery, whether it's a C-section or natural delivery, and the baby has a cardiac problem, how do you identify or are suspicious that this baby has a cardiac problem?
Cardio output? Cardiac output?
You're not wrong, but I'm waiting for more. I'm waiting, here's what I'm waiting for. I'm waiting for you to say, cardiac output because. See, when you just say cardiac output, you may not be wrong, but there's so many avenues. What?
Can I just say cardio output?
You're in the right city.
What it is I gotta figure out the rest for you. It's not that you're wrong, I just need a little more. Tell me. I thought you said something.
I said a blue baby.
Yes, he's gonna be cyanotic, very cyanotic. Well, how do you know that he's cardiac just because he's blue? If he has pulmonary hypoxia, he'll still be blue. And there's nothing wrong with his heart. Correct?
Blood gas?
There you go again.
I was just
You give me that much, and you let me figure
I'm
out
hoping
the
you
rest.
finish it.
Okay, I need more guys, come on. So you guys understand why you would,
You can't tell an ultrasound if that's the bigger problem with the heart, if they're.
you could tell. You could tell an
They would know
ultrasound.
before.
Correct, you could tell, and you need to order one. But at birth, this is a
At birth,
delivery.
looking at it.
Yeah, this is a delivery. Now look, you're not gonna look at the baby and go, he has a cardiac problem.
Yeah.
But the thing is things are gonna happen during the transition at birth that are gonna be abnormal, okay? The baby's normally supposed to take up to 10 minutes to get a saturation from approximately 60 to 65% up to 90 to 95%, okay? When we do things called APGARs, and we'll discuss that in the lab this morning, when we do things called APGARs, we assess the baby's functions, crying, respiratory effort, how he's breathing, in the first minute of life, in the 5th minute of life, in the 10th minute of life. It's called APGAR scoring. Okay? You score the baby. The better he's doing, you give him more numbers for the score. The worse he's doing, you give him less numbers for the score. Okay? So what you want to see is a baby that gets at least 9 points in each minute. Okay, I'll show you how to do that in the lab. Okay? The idea is whenever you go ahead and score a baby or you assess a baby to see how he's doing, you want to make sure that everything you check is good. Is his cry good? Yes. Is his tone good? Yes. Is he jumping around? Does he have good activity? How's his color? Is he nice and pink or is he pale? Those things need to have high numbers. When a baby is cardiac, all those things will not be high. When he has a heart problem, you're going to get low numbers on things, typically on color. Typically on color, right? What did we say we check when we do the resuscitation? And we said that when the heart rate is below 60, we do chest compressions and bagging.
Yeah.
Right? We said when the heart rate is above 60, but less than 100, we just bag it back. We said when the heart rate is above 100, we stop bagging, we monitor the baby, free flow oxygen, slowly withdraw it, right? Okay, now, if a baby's cardiac, what you're gonna see is you're not gonna see that the color is good. The babies that we just described, when we bag and we stop, we see a nice pink baby. Now we wanna check the heart rate, right?
Yeah.
Correct?
Yes.
The SAT is above, I'm sorry. The heart rate is above 100, look at the baby. What am I looking at? I'm looking at the baby's color, I'm looking at the respiratory effort. Because his heart rate is above 100, we know the heartbeat is coming up. I can detect that because the baby is nice and pink, and I also check the heart rate. That's how I know it's above 100. The baby's heart rate is 12 and 6 seconds. That's a heart rate of
120.
120. When I see that the heart rate is 120, I'm gonna look at the baby and see pink. Pink baby, yeah?
Yeah.
If he's cardiac, the baby will still be pale and or bradycardic. We just bagged this at, okay? Okay, we stop. The heart rate is 9 and 6 seconds. Keep going because it's less than 100. And the heart rate is 12 and 6 seconds. You know what? It's 120, but the baby is not pink enough. It's just not pink enough, okay? When we start to get into resuscitation, I'll show you how to detect those things. Two main reasons why the baby would not be nice and pink once the heart rate is above 100. Number one, perfusion. Perfusion, tissue perfusion. Number two, cardiac problems. Okay? So that's what you're looking for. When a baby is born, you look at him, you want to see nice and pink. Okay? Oh, the heart rate is 120, he's okay. No, he's not okay. He's not okay. What else can make a baby look pale?
That's surfactant.
Surfactant or lack of. There's a little guy. He's not pink enough. He's just not pink enough. He's term, but he's just not pink enough. See that? He should be nice and pink. Right? So, whenever a baby has that problem, you're gonna assume that there's either an issue with perfusion, there's an issue with surfactant, or what else? Cardiac. So, Maria is that on point there. What you wanna do now is you wanna do an ultrasound to see if you're in fact dealing with a cardiac baby. Okay, in the meantime, keep your FI2s low so that you don't cause problems with the oxygen, namely constriction. Okay? Okay? Good with that? So if you have a baby that has issues becoming pink, it could be perfusion, it could be cardiac, or it could be surfactant. Okay. Simone.